So welcome, everybody. We're very, very pleased and privileged that you took some time out of your day to join us. Uh, the organization that is sponsoring this talk, let me just introduce you to it, is the International Drs-say-no organization. And let me tell you a little bit about who we are. We are medical doctors from around the world who are committed to supporting people to both live and die with dignity and comfort. And we're determined that state-of-the-art care should be available for people who are dying and also for people suffering chronic disease, disability, or mental illness. In that regard, we believe neither assisted suicide nor euthanasia is a medical procedures, and doctors should play no role in the regulation or practice of euthanasia or assisted suicide because it is not medicine. We endorse the views of medical associations around the world, which hold that physician-assisted suicide and euthanasia are unethical, even if they're made legal. We have a manifesto that says that doctors should be left to focus on advocating for patients, to cure sometimes, to relieve often, to comfort always, and to kill never. Please encourage your medical colleagues and yourself, if you haven't, to consider signing on to our manifesto. And I am putting in the chat uh, our uh, our website, along with the website of our speaker today. And you can go to the website, and while you're there, not just read the manifesto and potentially sign on, but also to see many of the past presentations that we've sponsored, uh, presentations about palliative care, some of the adversities of the experience in the Netherlands, Australia, talk about these procedures for people with mental illness, the effects of Canadian made on palliative care in that country, and the risk to vulnerable people in Canada in light of the availability of these procedures. In case you can't get the chat, the website is drs-say-no.net, all one phrase, drs-say-no.net. All right, now to our presentation today. First, let me just a bit of housekeeping. We are going to use the Q&A button for your questions, not the chat. So if you have questions as we go along, please feel free to put that in there. The chat function is disabled, at least for the audience. And at the end, Dr. Sinead Donnelly and Dr. John Kleinsman, both from New Zealand, are on hand, and they will read out your questions at the end of the presentation. And today, our presenter is Chelsea Roff. She is the founder and director of Eat, Breathe, Thrive, which is an international charity focused on preventing and treating eating disorders. For over a decade, she's worked to expand access to interventions that combine psychological therapies, somatic practices, and peer support, particularly for those who've not been able to recover through standard treatment for eating disorders alone. Under her leadership, the organization has served more than 17,000 people across 58 countries, including communities in Saudi Arabia, Cameroon, Brazil, and elsewhere. Chelsea has co-authored several peer-reviewed studies on eating disorders, including 2 multi-site international randomized controlled clinical trials, and what I consider particularly important for today's presentation, she has co-authored a systematic review of the world's literature and evidence of showing more than 60 cases of individuals with eating disorders who died by legal physician-assisted suicide or euthanasia. I consider this paper to be at this point, the definitive study on this particular issue that she's going to be talking about today. She's now based in London, works internationally to advise policymakers and advocate for individuals and families affected by the illness that nearly took her own life as a young person. Chelsea, we're delighted that you can share your knowledge and experience with us, and I turn it over to you.
Oh, well, thank you so much, Mark. And it's a real honor and honored to be here today. I want to thank John and Sinead for inviting me. I'm, a huge fan of the work of Drs-say-no, and I'm honored by your comments, Mark, and would also say that your book chapter, which is in Patricia Westmoreland, it was edited in a book by Patricia Westmoreland, is still one of the most seminal works on this topic. Was a real help to me as I got educated myself. As you can hear from my bio, this was not really my niche prior to now, and so I'm happy to share our research. But I think right at the outset, I want to tell you a little bit of a story about how I came to this work to begin with. I'll tell you a little bit about our findings today, and go through those in detail. And then if we have time at the end, I'd like to share a little bit of some developments that are happening at a policy level around this topic internationally, particularly in the UK, where I live, and there are multiple bills being considered to legalize assisted death, as it's called here. So with that, I will kick it off. I just want to give a thank you right at the top to my co-author, Dr. Catherine Cookatone. We have worked together for many, many years, including on those randomized control trials that Mark mentioned. I'm not actually an academic researcher. I'm a community-based researcher. And when this came up, I reached out to Catherine because she is the person that I do all of my research with, and said, have you heard of this? There appears to be assisted suicide and euthanasia happening in people with eating disorders. And so anyhow, you'll hear the story here in a moment. But she is my co-author on this paper, and without it, it wouldn't be possible. So I want to start off, and I'm going to read here from my phone for a moment because it's a lot for this this slide. So it's going to be partially here, but I want to read a quote from an article published in 2022 in the Journal of Eating Disorders. She repeatedly told her family that she didn't want to die, that she didn't want to miss out on future time with her family, friends, niece, and nephew, but she just couldn't continue to exist this way. The emotional pain and anxiety were unbearable. She couldn't live a normal life, and she felt her body was too destroyed to recover. Her parents believed that in her last month, she was trying to die naturally by barely eating, reducing her fluid intake, and walking for hours daily, even when she had to sit down to catch her breath. She stopped driving and carried identification in case she collapsed on a walk. She fainted at home several times in the week before her death, including the night before she died. And then to this quote, on the day she took the MAID prescription, medical aid in dying, she stayed in bed and was at peace and spent time with each parent and her brother. Together as a family, they reminisced, laughed, cried, and had their hug circle, as they had called it since her childhood, and felt surrounded by love. Her parents each held a hand, and her brother sat right next to her. During the 3 doses of the medicine, taken over an hour, she was comfortable and conscious. Within 10 minutes of taking the final dose, she closed her eyes and her breathing slowed. So when I read this paper in which this quote was published, I was very surprised that it had come, because you could hear that and think it might have been about someone at the end of their life, in their maybe someone who's elderly, who has cancer. But I was surprised to learn it was actually from a 36-year-old woman with anorexia. Uh, we're not sure whether it was in Oregon or Colorado. It's not clear, but she died, and I think most likely in Colorado. But I'll share a little bit more about the data and why we can't be sure. But she died by what her doctors called medical aid in dying, and what others may call assisted suicide or physician-assisted death. In the paper, the physicians and the authors described it this way: a small group of patients may ethically decline care measures they no longer feel will be helpful. A subset of these patients will go on to die of the medical complications of malnutrition, while designated as having terminal anorexia. And an even smaller subset of these patients may choose to use medical aid in dying medications. Um, when I first read this, I was actually so surprised by what I was reading, and this is just my own. I was so surprised that I wasn't even sure if it was a real academic paper. I messaged Catherine, my colleague and my co-author on this paper, and said, "Have you read this? Is this a legitimate journal? This seems very unusual, given that in the United States, in only a small number of states, 11, 10 states plus Washington, D.C., assisted death is only legal for terminal illness." So I was reading a paper that seemed to be proposing a new clinical category, what some have called a pseudo-diagnosis, but a new category of an eating disorder that we don't typically think of as a terminal condition or a terminal illness, and arguing that individuals who represent this category should be afforded access to assisted death just like any other patient. It described the cases of three individuals, two of whom were prescribed lethal medications to end their life. One of whom was in California, and one of whom we think was most likely in Colorado, but could have been in Oregon, because it's not explicitly named in the paper. And the physician who prescribed the medication, who was also the lead author, or I'm using medication, the drugs, the lethal cocktail, was the lead author of the paper and was based in Colorado. And I should say that was served as consulting physician in one of the cases, and prescribing physician in the other. So we were really, really shocked. And right around that time, we started seeing a lot of articles hit the mainstream media around this particular academic paper. It hit the New York Times, and we see this headline: "Should patients be allowed to die from anorexia?" And it was in the Washington Post. Should anorexia ever be called terminal? To date, this academic article has been accessed tens of thousands of times. I think it was 19,000 when I last looked, but it's been a while, and has been highlighted in multiple mainstream news articles, really spreading this idea of terminal anorexia or terminal eating disorders around the globe. And again, I have to say, this was based on a medical case report with that described three cases. So again, we were concerned and alarmed. And I should also mention, we saw at that time a real outcry from the academic and the clinical community. Dozens of papers were published in response. I didn't see a single paper that was really affirming the idea of terminal anorexia. They were all, in a collegiate manner, critical of this concept, but it nonetheless seemed to be spreading. And what I know from working with people with eating disorders is that often an idea like this becomes another benchmark to reach for when a person is really ill. So it's, I'm not sick enough. I'm not sick enough until I am the sickest. There's almost a competitive energy. So I was really concerned, but at the same time, we thought, well, our colleagues are publishing papers. This seems to be addressed, so maybe there's nothing to worry about. I should say, actually, I'll go back here for a moment. That shifted when we were at a professional conference just last year, actually, and the topic was a huge topic of conversation at the conference. There was a panel that was presented that was numerous speakers spoke, one of whom was the lead author on the paper, who apologized for the term terminal anorexia, but continued to suggest that there was a a clinical stage at which anorexia can become terminal, and was very clear that she believed that people who fit this quote, terminal stage, would be eligible for assisted death, even in countries and jurisdictions that limit the practice to terminal conditions. Um, I also, at the conference was speaking to colleagues and attending other presentations, and it became abundantly clear that it was not an isolated practice. I attended one presentation that was presented by clinicians in the Netherlands that showed some data out of the Netherlands where people with eating disorders had been granted access to euthanasia. And so it was, it was just unfold. I share this with you only to give you a sense of how this study came to be and why Catherine, my co-author, and I, really dropped what we were doing in our professional lives to do something that was completely out of our area of expertise. To be quite frank, we've both spent our careers, Catherine more so than I have, researching prevention interventions and treatment interventions for eating disorders. So this was a real departure. But the reason we decided to do it is because it was clear that it was not an isolated practice, and there was almost no data on it in the literature. In fact, the chapter that Mark wrote in this book with Annette Hansen was one of the only really good articles and pieces of work we could find on it. And there were just scattered case reports from the Netherlands and Belgium. So we wanted to answer questions that we had and make sure that the field was fully aware of the data on this, just because there was just a complete lack of research. I can't even say there was little research. There was almost none. So we had three major research questions in what became a systematic review. I can't say that we at the outset realized that we were going to have to do a systematic review, but it was clear that was what was necessary with our research questions. So our research questions were: how many people with eating disorders have died by assisted death globally? And that's inclusive of both assisted suicide and euthanasia. And we were particularly interested not just in people with eating disorders who had co-occurring terminal conditions, but people who were granted or who were deemed eligible for assisted death for reasons specifically related to an eating disorder. We wanted to know where these cases had occurred, and most importantly, we wanted to better understand the medical reasons or the clinical rationales that were provided to justify eligibility for assisted death. So those were our research questions. I always include this slide when I do presentations because there's the language and the lingua franca on assisted death is a minefield, as I'm sure many of you on this webinar will know yourselves. I was not aware of what a minefield it was until I really dug into the literature on this. And there's many terms that are used to talk about what is at its essence death by lethal medication. Generally prescribed or administered by a doctor, but increasingly also by nurses and physicians associates, as some countries loosen some of the legislation on this. The terminology you use often gives away your views on the subject. It is loaded language for certain. And one of the things that I learned really early on, and I read it in a paper, and I wish I knew which paper it was because I would cite it here, but it was something along the lines of sometimes terms are selected or rejected in order to shape public opinion. So I must say I was quite naive early on. I didn't realize what a politicized issue it was, and it is a politicized issue. Again, you see euphemistic terms like medical assistance in dying, death with dignity, dying with dignity, and facilitated aid in dying. And then there are also those in who are very campaigning groups and activist groups who take real issue with the term assisted suicide and feel it's very important to distinguish a particular kind of assisted death that doesn't fit within the category of assisted suicide. So my pragmatic decision on this has just been to use assisted death because it says what it is, and it can broadly encompass euthanasia, which is the lethal administration or the administration of lethal medications by medical professionals, and also what is called assisted suicide. Which is when a person takes those medications themselves, and increasingly we're seeing sometimes it's not orally, it may be using devices, but the final act is supposed to be by the person themselves. So I'll use the term assisted death in this presentation, and when talking about specific jurisdictions, I will use sometimes jurisdiction-specific terminology there. So how it is referred to in the country itself. One of the first things we wanted to do in this study was just wrap our heads around the legal landscape, and also help our colleagues in the field of eating disorders understand the legal landscape as well. It is a landscape that is constantly changing pretty much every few months. So even this map, which was published in our paper last year in August, may be slightly out of date at this point. And it's difficult to categorize laws because every jurisdiction is slightly different. But broadly, of course, anytime you try to put something into a category, you lose detail. But broadly, we found that these laws legalized assisted death in different ways. And there were some jurisdictions, most notably New Zealand and the states of Australia and many states in the US, that had legalized assisted death on the basis of the person having a terminal illness or terminal condition. So the person has to be terminally ill in order to qualify, at least ostensibly terminally ill. And there were other countries in the world that had said, well, you don't have to have a terminal illness necessarily, but you must have an irremediable or an incurable illness that cannot be improved or reversed by treatment. I will say these green ones here, there's a lot of nuance that's lost in just putting it under that category, because there are some countries that talk about unbearable suffering, which is quite hard to objectively define, and varying definitions of irremediability itself. But for the sake of at least you always lose detail in these broad pictures, but for the sake of giving people a picture, we wanted to put this out. The lighter blue squares are countries where, at the time of us writing this article, did not have full regulations set out. And in most cases, that was because the laws had just recently been passed. In Montana, which is a bit of an outlier, it's because it was a case in the courts that led to the legalization of assisted suicide, and it hasn't really been fully regulated ever. There is some legislation going through Montana at the moment that's seeking to walk this back, but that's the ones in lighter blue. And then you have the real outlier in terms of all of these jurisdictions, which is Switzerland, which is colored in pink on the right. It is the country that stands out as having assisted suicide, as it's called in Switzerland, legal the longest, since 1942, but also the country with perhaps the least restrictive laws around this practice. In Switzerland, you don't have to have an incurable illness, you don't have to have a terminal illness. The person who's doing the assisted suicide just has to not have non-selfish, just can't have selfish motives. And I'll speak about this in a moment, but Switzerland also, I would say, has it is one of the hardest countries to get any data. So I would venture to guess that the that there is and this is a guess, but that there will be people with eating disorders that have been assisted in death in Switzerland, but there is so little reporting and little centralized reporting that we were not able to confirm or rule out cases at all in Switzerland. And it certainly has the highest volume of assisted deaths since it's been legalized. This is not an exhaustive table. There is a much bigger table in our paper itself, but I wanted to at least show the top of this table and point to the countries circled in red are the countries where we focused our systematic review. So the United States, the 11 jurisdictions in the United States where it's legal, the Netherlands, Belgium, and Luxembourg. Again, we would have liked to have done it in Switzerland, but it was not possible due to the lack of central reporting. And I have to say, I look back on this, and it hasn't even been a year, and we feel compelled to do an update to our paper. I think I was a bit naive when we began. I assumed the reason that we focused on these jurisdictions is because we assumed that there would not be cases of assisted death in people with eating disorders in countries where mental illness was not where it wasn't legal on the basis of mental illness. I now know that I was likely mistaken on that, because of course in the United States, assisted death is not ostensibly legal for mental illness alone, and yet we have cases there. And since publishing the paper, we've had colleagues and families reach out and make us aware of cases in Canada, for instance. So we are due for an update, but we all to say we did not look at the data in Australia, New Zealand, Spain, Canada. So I can't confirm or rule out cases in those countries. And anecdotal reports indicate there may be more cases than even the ones we found in our study. Okay, and this brings me to, I think, what is perhaps the most least climactic, but perhaps I think one of the most important findings and most generalizable in terms of this issue, more broadly, findings at our study. And that was that in most countries, there is only very limited data available for public scrutiny and for scrutiny and research by academics. As I mentioned earlier, Switzerland, which has the least restrictive laws on assisted death, has no centralized government reporting at all. Only recently have there been efforts made to identify assisted suicides on the death certificates, but we cannot determine how many assisted deaths have occurred since it was legal in Switzerland. And certainly we reviewed the academic literature on assisted death and mental illness in Switzerland. And while we could see that there were, and this is discussed in our systematic review, there are certainly assisted suicides for reasons solely related to mental disorders. The diagnostic category of mental illness is not listed with enough detail to determine whether eating disorders were within those academic studies that were done. So there's just a real big question mark over Switzerland at the moment. I have to say, the Netherlands is in some ways one of the most, I should be careful with my words. The Netherlands is often in media portrayals kind of portrayed as the country where there's just free reign on euthanasia. But I have to really celebrate the Netherlands, because I would say it had the best reporting, the most transparent reporting of any country where we attempted to get data. And yet, even in the Netherlands, only 19% of euthanasia or assisted death cases for reasons solely related to psychiatric reasons identified the diagnosis. So to put that another way, there are actually the most recent annual report from the Netherlands actually has just come out this week, and I read it this morning. And there was a sharp increase an increase of actually 59.6% this year in reports of euthanasia for reasons solely related to mental illness, and actually a new category they've created this year, just as an aside, on euthanasia for reasons related to mental illness with co-occurring physical illness, which is interesting. And that's an additional, I think, 90 cases. So there's been a sharp increase. But of those cases that are reported in the annual report, which will say how many cases occurred and what percentage it was of the total euthanasia cases that year, that annual report does not break down psychiatric diagnosis. However, the Netherlands publishes a select number of case reports on the euthanasia cases from the year, and about 19% of all the psychiatric euthanasia cases are published as case reports. This has varied year to year, so I'm giving you 19% of all of the cases, all the psychiatric euthanasia cases from about 2008 until this year, and they have started publishing fewer, but there are cases there for us to look at, and those cases were a real boon for our research, because they describe the patient, their diagnoses, the circumstances that led to their euthanasia request. And so those were the cases that we could look at very closely to identify the medical reasons that were given for this person qualifying for assisted death. And that's in addition to, again, scattered reports, medical case reports in the academic literature. So to summarize all of that, our systematic review looked at government reports and the academic literature, and transparency was lacking. And that is important, because when we say we found at least 60 cases, there, in most places, the data was in a black box. We couldn't confirm or rule out assisted deaths in people with eating disorders. And there are almost certainly more cases out there, given the countries in which that occurred, and the numbers of eating disorder cases we found in the data that was available. But that's where we reviewed. We also looked at the United States, we looked at the Netherlands, we looked at Belgium, and we looked at Luxembourg. And I shall tell you a little bit now about what we found. So high level, again, as I said, we identified at least 60, and that's why there's a big plus symbol here, confirmed cases of assisted death, or for assisted death for reasons specifically related to an eating disorder. So this is where the eating disorder was the primary qualifying condition for euthanasia or assisted suicide. And I have to emphasize, this includes in 3 US states where assisted suicide is only legal for terminal conditions. So we've been able to identify confirmed cases with the state agencies in California, Colorado, or Oregon. However, those agencies cannot tell us how many cases have occurred. So they have stated, we can confirm that anorexia has been listed by name as a terminal condition in the state, but we cannot disclose how many cases have occurred. So that's why I say, again, at least 60. I have heard our study represented in media reports as, oh, it's just 60. It's not that many, or it's only 1 or 2 in the United States. But we cannot say that. In most states, we couldn't get the state agency to respond at all. And then in the states that did, we know it's 1+, but we don't know how many. Looking at the data, I think we expected, I don't know what we expected really, but I do remember being a bit surprised by some of the demographic characteristics, which we can go into now. 1 in 3 of those who died, and I should say 100% of the cases that we reviewed were women. But 1 in 3 of these women who died were in their teens or 20s. So the bottom end of the age range was 18. And the top end, I don't know the top end, I think it was in their 60s or 70s, but a third were in their teens or 20s. I'll discuss this more, but 95% of the cases we reviewed in these cases, physicians or doctors stated that the person had an incurable or untreatable eating disorder. None of the cases that we reviewed did we find that the women who died had comorbid organ failure or other terminal conditions like cancer. So I think that's really important to understand. Again, the primary diagnosis and reason for requesting euthanasia or assisted suicide was an eating disorder. In 100% of these cases, the patient was assessed as having capacity to decide to die by assisted death. I emphasize this because as I've sort of gotten plunged into the policy conversation around this, which is new for me. I'm not normally involved in conversations at Parliament, but I am increasingly, and I've heard many academics, policymakers, clinicians say, well, a person with an eating disorder would never qualify for assisted death because they would lack capacity. That is not what our data showed. Our data showed that all of the known cases, doctors assess the patient to have capacity. And I'll discuss this later in the presentation, but there's an important distinction in capacity assessments between capacity to decide to die by assisted death and capacity to make decisions about one's treatment, which in the case of eating disorders is around often nutrition. So that may be why we see that disparity, but I'll discuss that more. And then in California and Colorado, this was really striking. In California and Colorado, when we looked at the annual reports on assisted death, anorexia nervosa was not listed as a terminal condition. So the only reason we knew that cases had occurred in those states was because of the study that I mentioned, the medical case report I mentioned at the top of the presentation around terminal anorexia, which reported on the deaths of 2 patients, one in California, one presumably in Colorado. So when we went to the annual reports expecting to see anorexia listed in those years and didn't find them. So we went to the oversight agencies, and the oversight agencies confirmed that anorexia had been listed by name as the primary terminal condition. But when we asked, why is it not in the annual report? They said, oh, it's in the other illnesses category. So there is, we'll go into this later in the presentation, a category at the end of most of these annual reports. There's a catch-all category, which is other illnesses. And I mention this only because if that paper had not been written in 2022, we would never know that these cases had occurred. The public would not know that these cases occurred. Researchers and clinicians wouldn't know these cases had occurred. So I think a real public safety concern there around lack of transparency. Okay, so we identified 60 plus, at least 60 cases in total. 19 of those cases had full details, had case reports, not just in the Netherlands, also in the United States because of the study that was published there. So we were able to analyze 19 of the cases. There's also, I believe, there was another one in the academic literature, which I'll discuss in a few moments. And in those 19 cases, what we did is we analyzed the medical rationales that were given to justify eligibility for assisted death. And we also looked at the demographic characteristics of these 19 individuals who died. I mean, really striking data here. 95% of the women had one or more psychiatric conditions. 61%, nearly 2/3, had 3 or more comorbid psychiatric conditions. Personality disorders were strongly represented in this data set. Nearly half were diagnosed with a personality disorder of some kind. There were 3 individuals who had autism in addition to an eating disorder. 52% had a diagnosis of a depressive disorder, 32%, a third, had obsessive compulsive disorder, and over a third had PTSD. So a real high acuity psychiatric population. One woman was described as having an intellectual disability. And these were all, again, individuals who were deemed eligible for assisted death. Looking beyond just the diagnostic categories, we also looked at the other mental health variables that were reported in the cases. I mean, strikingly, over half, 58% of these individuals were reporting suicidal thoughts just before they made the request to die, and 37% had previously attempted to take their own life. We know suicide is one of the leading causes of death in eating disorders, so this is not surprising in terms of the demographics and the characteristics of the eating disorder population more generally, but perhaps surprising that that these variables were present and the request for an assisted death was still granted. 17 of the 19 patients, all but two, were described as depressed. Maybe didn't have a depressive disorder, but were described as depressed. 2/3 were described as having anxiety. 26% were described as having frequent nightmares and flashbacks. And I have to say also, I think just to give you a sense, well, there's a lot I can say about this data. Let me keep moving just out of the interest of time. But I'll also just mention that 26% were physically disabled. So again, quite a lot of co-occurring conditions here. I want to give you some quotes to really just bring out the stories, because the stories of these individuals are what struck me the most. This was a patient in who we think was in Colorado, and it says here, as she felt progressively miserable physically and psychologically, her suicidality increased. She purchased a gun, and one night she drove to a bridge with thoughts of jumping off, but then decided to return home. She repeatedly told her family that she didn't want to die, but she just couldn't continue to exist this way. So this was a 36-year-old woman who died by physician-assisted suicide, again, in a US state, who clearly was suicidal before her request. The physician, this is the same case, spoke with Jessica's parents repeatedly, assuring them that guardianship and forced treatment were not now likely to be futile. So we see this narrative of futility emerging here. High level, we saw what we have come to call a fatal pathway, and it was we cannot extrapolate causation here, but it's something that we know from our clinical experience happens often in eating disorders. And that is, there is a presence of severe malnutrition. So at least 68% of the patients were severely malnourished or underweight when they made their request to die, which of course has effects on one's mental health and cognition. So 89% of these patients were depressed. 26% reported flashbacks and nightmares. And we do know that there is a connection between malnutrition and alterations in mood. We see someone get very malnourished, perhaps become depressed and more anxious, and then perhaps over time, as treatment is not successful, start to doubt the worth of their life and start to doubt whether they want to continue living. And then at the end of this pathway, and this is really for the first time, at least that we're seeing this in the last decade or two, there is now the possibility of, in that moment of despair, when someone is feeling very suicidal and is depressed and doesn't have their full physical and cognitive faculties intact, being prescribed or administered lethal drugs. And what was striking to me in this data is that despite the presence of these psychological and mental health symptoms, 26% of the physicians stated that the patient's desire to die was not a symptom of mental illness. So I don't know how they discerned that distinction, but I did find it a striking one. Another example from the US, and often, we really see this new narrative of futility come out, which we'll discuss in a moment. Alyssa's parents asked whether any treatments remained that might yet change the outcome of her course, specifically noting that Alyssa had not completed a full residential eating disorder program, which I have to emphasize, this is part of evidence-based treatment for eating disorders. She had never fully restored her weight. Weight restoration is one of the only good predictors of eating disorder recovery we have, and certainly it's not the only part of recovery, but it is a necessary step in recovery. So I would argue that if she'd not restored her weight, she had not had adequate treatment and had never received a feeding tube. And yet the physician noted that and told the parents, if someone restricts the tube that God gave them, i.e. their esophagus, they would be very likely to restrict their food through a surgical feeding tube. So that would not be a long-term solution. So that brings us nicely to the next part of our analysis, which was the medical reasons and the clinical rationales that we saw cited to justify eligibility for assisted death. And we categorize these in three major categories, which not line up with the legal framework for assisted death quite neatly, likely because in the cases, the doctors are often, describing, well, this person is eligible because they meet X, Y, and Z, and those X, Y, and Z are often legal eligibility criteria. So three that we noticed, and we called this kind of the three domains: the terminality domain, the irremediability domain, and the voluntary domain. And I'm going to go into these one by one, but what was very striking is that in these first two domains, much of the terminology that was used is terminology that in the eating disorder literature is still somewhat theoretical and in development. These are not clinically valid terms. So severe and enduring eating disorder, while it is a growing body of literature and a very important body of literature, there is no agreed upon definition of severe and enduring eating disorder, and it's often defined in different ways across different papers. There's very little outcome research on individuals that meet this somewhat undefined category. And there's also been an outcry, and well, maybe not an outcry, but certainly criticism in the field from those with lived experience of eating disorders who have taken issue with some of these terms and their use in clinical decision making. So we saw these terms that are very amorphous in the literature itself being used and cited as justification for death. Which was concerning because they're not well defined, and there's a very kind of nascent evidence base would be the kindest way to put it on them. And then in the irremediable category, we saw, Mark is much more familiar with this literature than I am, and I am in debt to him for his writing and his colleagues' writing on this. But we saw, futility often cited, so the idea that any further treatment would be futile. We saw patients described as resistant to treatment, although that is, again, not a well-defined term in the literature, and certainly not one that we should be using to make clinical decisions, given the lack of and the real dearth of evidence and lack of definition. So some real concerning clinical rationales emerged there. And then, of course, we saw in the voluntary domain these others that are much better, have much stronger definition and clearer evidence base in terms of how they're defined and assessed in the literature. Mental capacity is an excellent, a very large literature base. However, the literature on mental capacity assessments in anorexia is lacking, and eating disorders more general is lacking. So again, I'll go into these in more detail here in a moment. So the findings in terms of clinical rationales, I just wanted to mention a few of the characteristics that came with the clinical rationales before I go to each one independently. I would say that one thing that was striking is that in many cases, over half, the person was described as having an irremediable condition. And this is a quote, according to prevailing medical opinion. Previous physicians had rejected or refused the patient's request in just under half, 42% of cases. So we saw, what is sometimes colloquially called doctor shopping. And then heartbreaking to me is that there was 2 cases in which the patient had been rejected or previously discharged from prior treatment, and a number of other things here that are this is in the systematic review itself. So you're welcome to go see it. So in the terminal domain, we saw really two justifications emerge. One is we saw patients that were described as having this what has been called a pseudo-diagnostic category of terminal anorexia, and that was in this paper that emerged. Again, not well defined in the literature. And then in other cases, and sometimes in the same case, we saw eating disorders, the physical complications or the physical sequelae of eating disorders cited as evidence of terminality. So these are liver dysfunctions. It could be starvation-induced hepatitis, renal dysfunction, terminal malnutrition was a term that we saw used in these cases. And so these are typically, and the research suggests they are nearly all reversible with weight restoration and adequate nutrition intake and recovery, but they were cited as kind of terminal conditions of their own accord. Here's an example quote from the paper published in 2022. Even with terminal malnutrition, having lethal medications at hand would give Alyssa the opportunity, while still having an intact brain, to choose not to suffer. Here we see a claim make: anorexia nervosa is the only eating disorder that carries a guaranteed medical cause of death from malnutrition should weight loss continue unabated. And here we see, consistent with the literature on managing terminal illness, this article proposes clinical characteristics of patients who may be considered to have a terminal eating disorder. In our view, these patients deserve the same attendant care and rights as other patients with terminal illness, up to and including medical aid in dying in jurisdictions where such care is legal. So we saw this really used, again, you can see clearly here, as a justification for lethal medications. It almost appeared as if the criteria for terminal anorexia were directly aligning with the legal eligibility criteria for assisted death in the US. I want to speak a little bit to the irremediability domain, because there were some really interesting results that came out here. There was, in 95% of cases, the patient's duration of illness was cited as evidence that they were unlikely to recover, which is again not a prognostic indicator in the empirical literature. So we cannot use duration of illness to predict who will get better and who will not. Many patients will surprise you. Sometimes they're ill for decades, and suddenly something sticks, and it's one of the most gratifying experiences I can say as a person working with these individuals. But we cannot use duration of illness as a predictor of irremediability for certain. In 89% of cases, doctors argued that treatment has not produced any results, and thus it never will. So there was an assumption there that if treatment has not worked yet, it is unlikely to work in the future, which again is quite a leap to make, at least on an empirical basis. And then I think really just striking to me, in nearly half of reports, 47%, we saw the phrase, and this is verbatim, healing was no longer possible. So really quite nihilistic narratives emerging here. Give you some quotes because I really think they speak for themselves. The patient felt trapped between her eating rituals and untreatable gloominess. The patient had been exhaustively treated for her depressive complaints and for her eating disorder. Despite the young age of the patient, no realistic treatment options were available. This was a patient that was described as between the ages of 18 and 30. Who had anorexia and OCD and depression. So untreatable gloominess is It's not something I have seen in diagnostic textbooks before. She was chronically depressed, which caused her to constantly struggle with suicidal thoughts and expressed this by attempting suicide. The doctor was also convinced that the patient's suffering was unbearable and, according to prevailing medical opinion, hopeless. This was a 40 to 50-year-old. And we saw this phrase, according to prevailing medical opinion, come up over and over again. So there's really this kind of air of certainty and medical opinion justified. And I'm not sure that according to medical opinion, it's unclear what that means. Due to the complexity of her conditions, the patient was frequently rejected for treatments and discharged during admissions. This just broke my heart. This patients that were, unable to access treatment, and this made the patient feel rejected and desperate because she could never get appropriate help. According to the doctor, this chance of success of any subsequent treatments was small. Mark, I hope it's okay. I'm going to zoom through these next two and finish up the final domain, and then we can go to questions if that's all right.
That's fine.
Okay, excellent. The patient's suffering consisted of the untreatable eating disorder, the constant high level of anxiety and tension, severe nightmares with flashbacks. The psychiatrist found the patient's euthanasia was to be comprehensible and respectable. Her mood was stable. The patient could not live with the untreatable consequences of her trauma. And I emphasize this because in the UK, we're seeing a lot of MPs say, well, no one would ever describe a person with an eating disorder as untreatable. No one would ever say that a person has an untreatable eating disorder. And I must say that is not what our data suggests. The final domain I want to discuss just briefly here is really important. So in every single jurisdiction where assisted death is legal, a person must have decision-making capacity to make the decision to die. However, I want to just say this really clearly because I'm seeing that I'm seeing it get misunderstood quite often in Parliament at the moment. Decision-making capacity is decision specific. So a person can, for instance, can have capacity to make a decision about what they want to have for breakfast or what they want to wear that day, but not have capacity to make decisions about their treatment. And that's it's a whole literature on that. So in 100% of the cases we looked at, patients were assessed to have decision-making capacity. This table is a little confusing, but what it's articulating with the 95% is in 95% of cases, it was emphasized. But in all 60 cases, the patients with eating disorders were deemed to have decision-making capacity to decide to die by assisted death. That doesn't mean necessarily that they lacked capacity to make decisions or that they had capacity to make decisions about treatment. So right now, what I'm seeing a lot of in Parliament is MPs saying, well, and clinicians saying, well, people with anorexia lack capacity, as if it's a characteristic of the person. It's not. It's a decision-specific assessment. And so it's very possible that a person may lack capacity to make decisions about eating disorder treatment and their nutrition and hydration, but still be assessed to have capacity to make the decision to die by assisted death. And that nuance has been lost. I can't say with real confidence that capacity was assessed in a sound way because there's not great data in the cases, but I did see some concerning things. I often saw, in multiple cases, we saw a patient's intelligence cited as evidence of capacity. And I'll give you a few of these. I'll also just mention this article by colleagues is a great piece. And there's also a book by this lead author in Patricia's book on mental capacity and anorexia, which suggests that clinicians often don't agree on which patients have capacity to consent to treatment and which don't. So here you can see how the capacity decisions were made. She was able to weigh diagnostic information well and translate it to her own situation, and she had the ability to weigh information. This doctor felt confident that there were no internal or external factors that could have possibly influenced the patient's choice, despite the fact that she was diagnosed with anorexia nervosa, which one might argue is an internal factor. The wish for death was durable and consistent. despite the fact that the patient had always embraced the offer of therapeutic aids and was still willing to try possible experimental treatments at the time of conversation. She was decisionally capable regarding her wish for death, despite her depression. So you see in this a physician saying the person may be depressed and may be very ill. She may have chronic anorexia, OCD, and depression, but still had capacity to die by assisted death. I'm going to skip over some of these. I think the last one here I'll just mention was just one that struck us. There was an academic paper that detailed a case in which a person with anorexia between the ages of 30 and 40 chose to die by euthanasia and donate her organs. And that was really the subject of the paper, was organ donation in psychiatric euthanasia. And you see this real kind of benevolence emerging in her discussion of why she's chosen this. She deeply wanted to grant other people a new chance for a healthy and happy life, although it was no longer possible for her. Okay, I am just going to skip straight. Well, I'm going to just mention this one really quickly. I'm going to mention a couple interesting findings here. Please forgive the quick moving between slides. Colorado annual report 2023, we see for the first time malnutrition listed as a qualifying terminal condition, 12 cases over the past few years. So I want to flag that. We don't know whether those patients had anorexia. The more you look in this data, the more you find the Oregon annual reports. We have seen HIV, AIDS, diabetes, alcoholic hepatic failure, and more arthritis, complications from a fall, and anorexia listed as a qualifying terminal condition. So this is not limited to eating disorders. And then increasingly, we are seeing voluntary stopping of eating and drinking discussed as a bridge to assisted death to bypass terminal illness criteria. And I think we're starting to see that borne out in the data. So we're seeing depression discussed as a disease and voluntary stopping of eating and drinking as a bridge to MAID. So I will end there. I'm sorry I went a little bit over, but I'm happy to take questions. And I didn't realize until I made this slide how much work has come out on this topic recently. So I'm happy to share slides with Sinead, John, and Mark if you'd like to distribute them. And there's links to all this work and further slides to look into.
Thank you, Chelsea. Brilliant, concerning, in many ways shocking and staggering. So I know that John and Sinead were going to read out questions. Why don't we begin? I have some questions of my own, but why don't we begin with someone from the audience, from the Q&A. John?
Thank you, Mark. There's a question here from Adrian. Is the most important fact that AD is being extended legally to eating disorders? And is this showing to what extent illegal involuntary euthanasia is already being performed around the world, across the globe?
That's a great question. I'm not a lawyer, so I can't necessarily answer that question, but I will say this. My observation, having dug into this data, is that assisted death is expanding not just through legal amendments, but through clinical and legal interpretation of statutes on the books. So what I mean by that is if laws are not written with enormous detail and clarity and specificity, a lawyer or a doctor can interpret the words on the page in various ways. Just put it kindly. So for instance, we have seen diabetes interpreted as a terminal condition because a person refuses treatment. So even though the Oregon statute says it has to be an irreversible condition, if a person is refusing treatment, there are some lawyers who will say, well, the person is refusing treatment and therefore practically it cannot be reversed because a person has a right to refuse treatment. So I don't know if I would say it's illegal. I would say that there's broad interpretation of the laws happening globally at the moment.
Chelsea, thank you. Just to say, Adrian has a second question there, but it's probably a comment just saying that the rationales under the irremediable domains, they're actually applicable to common non-terminal chronic diseases. It's just an extension of what you just said.
Yes, I didn't have time to go into it fully, but I think diabetes, HIV, we're seeing those rationales made around, well, we're seeing them listed as terminal conditions, and I think the same rationales would apply.
Enrique has a question. Thank you for your brilliant presentation. I'd like to get some comments on voluntary stopping of eating and drinking.
Thank you for asking this question, because I was hoping to go into this and was mindful of time. I was ambitious with my number of slides, I now recognize. So voluntary stopping of eating and drinking is something that we have seen discussed in the academic literature as a, quote, bridge to MAID. So the what's been put forth is the idea that if a person stops eating and drinking, they're voluntarily, while they have capacity to make the choice to do so, their death is likely within days or weeks, not even months, and thus would meet the definition of terminal illness in some countries. That has, I didn't have time to go into this in my slides, but I'll just read you. That has, there was a really interesting ethics consultation that was published by the American Clinicians Academy on MAID, which is the professional body that kind of regulates, well, I wouldn't need to say regulates, but is it's a professional body on for MAID providers or assisted death providers. And I'll read, I'm quoting from that report. Legally, there is nothing in the letter of the law of any of the US states' aid in dying bills that explicitly prohibits voluntary stopping of eating and drinking as a terminal diagnosis to qualify for aid in dying. This remains a legal gray zone. And then it continues, opening access to aid in dying via stopping of eating and drinking would essentially eliminate the criteria of terminal illness to qualify.
Chelsea, you're bringing out this issue about the fungibility of legal interpretation. In most jurisdictions, nothing is explicitly said forbidding psychiatric conditions as making people eligible for this. So the lack of language forbidding it leaves open the door of using these kinds of legal reinterpretations to open the door wider to all psychiatric illnesses, as we're beginning to see. I wanted to ask you specifically here, these patients, these anorexia patients, can be particularly exhausting and frustrating to treaters. In fact, anorexia may actually be one of the most difficult to treat conditions in all of psychiatry. So how much do you think a clinician's justification for assisted dying and conclusions like no effect of mental illness on capacity represents the clinician's exhaustion and feeling of futility? So they're actually addressing and treating, if you will, their own feelings of futility more than the futility of the illness itself.
I think that's a very astute point, Mark. I think that's a real possibility. I mean, I would only just say, it is exhausting at times, and it's also one of the most gratifying, to work with, because seeing people make a recovery is extremely gratifying. I know in our field right now, eating disorders have one of the highest mortality rates of any psychiatric disorder, and they are at a policy level one of the most expensive to treat as well, because often when a person develops a very severe eating disorder, they may need many months of very high level care, sometimes in acute hospitals. So I'm seeing kind of a collision of things happening. There's a resource issue, to put it bluntly, around having the resources at an economic and healthcare system level to treat people that are developing more and more severe eating disorders. And then there is the almost moral exhaustion that comes from being a clinician in that field, of having limited beds, fighting insurance companies in the US, and having patients that are presenting more and more ill and having, fewer resources to treat them. So I do think that creates a feeling of futility. And I think that self-reflection is really, really important. I also think that part of it is that eating disorders are not being treated early. And when a person develops a very severe eating disorder, it becomes harder to treat. So we're seeing more severe eating disorders being presented, and sometimes in some settings, less use of evidence-based treatments that we know work, because sometimes they can be quite difficult to deliver. Refeeding is not easy, but it's necessary. Weight restoration is a necessary component when someone's underweight. But that's being used less often. So people are getting discharged at lower BMIs. Their illness is becoming more intractable, and yes, that creates exhaustion. I hope I haven't gone all over the place with that, but just some thoughts.
All right, we have 2 more questions left in Q&A. Why don't we try to attend to those, and then we'll wrap up. Sinead, you want to read out another?
Sorry, this is from an anonymous attendee. They're saying question is a tricky one, as it comes more down to ethics and influence. Eating disorders do cause significant suffering, as well as other psychiatric illnesses. So this is I do not think assisted dying should be permitted in general, and specifically for patients with eating disorders, due to the trickiness in practice and legislatively of safeguarding, in brackets then, especially as doing so will limit incentive to promote and invest in treatment options. But at the same time, and it sounds as if the person speaking from England, given the treatment, at least in England, is very limited and insufficient for all eating disorders. So if assisted dying were to be implemented and the scope wasn't narrowly defined, where do we go with that? So I suppose they're opening up, they're saying how serious this predicament is going to be.
Yeah, so I think the question there is a pragmatic one. If and in some ways the UK is confronting what's already happening in the US. So if a law goes through and a person with an eating disorder is eligible under that law, then what? It's a really, really tough question. I think this isn't a direct answer to your question, but I want to say it. What I found striking about the debate in Parliament most recently is a real refusal to acknowledge that people with eating disorders may qualify under the law. So eating disorders are not terminal, and eating disorders no one would ever say that an eating disorder is untreatable, or eating disorders can be reversed by treatment. So at minimum, I would like to see an acknowledgement and real transparency around what's happening, so that we're not in this predicament we have in the US, where the only reason we know about cases is because someone decided to publish medical case reports. There should be transparency within services, transparency at a government level on the demographic characteristics, previous access to treatment, or not previous access, but previous treatments tried, so that we can really understand if there are parts of the eating disorder population that maybe are being we can ask the question, were all available treatments tried? Is this occurring more in particular racial or age or gender groups, or people with co-occurring diagnoses? That has to be transparent. But right now, to quote a friend, Liz Carr, she said it's like MPs are putting their fingers in their ears and going, no, just don't want to acknowledge it's happening. And I think that that kind of that lack of acknowledgement creates a really dangerous landscape.
Just to illustrate the fingers in the ear, there was a point where they were refusing testimony from the Royal College of Psychiatrists to Parliament on this bill. John, can you read our final question, please?
Sure, from Evelyn. Were there in any of the cases that you reviewed a stated minimum BMI or physical criteria to reach that the physicians then felt satisfied that their weight was not affecting their capacity for decision making, for example, in a relapsing or remitting case?
Stated minimum BMI, physical criteria to reach, that the physicians felt satisfied there. I can answer that. There was no indication of that in the data whatsoever. One thing that was striking is that not all of the individuals with eating disorders who died by assisted death were underweight. Some were at a normal or above. We don't know what their BMI was because it wasn't clearly dated, but We're not named as underweight. And I did not read a single case in which BMI, there was a kind of connection drawn between BMI and capacity, whereas, a BMI of a certain threshold would be understood that that person would lack capacity. So to say that more clearly, there was never any discussion of, well, if a person has a BMI of less than 12, then we might need to worry about their capacity. That was not part of the discussions. If anything, BMI and the physical state of malnutrition was cited as more justification for the person's the fact that they're less likely to get better, less likely to benefit from treatment, and that this is the kind of only compassionate option.
Wonderful. Well, thank you so much. I want to remind everybody that if you've signed up for this, you'll be on our mailing list, and we'll send out the link so that you can not only have this recording, but you can distribute it to colleagues. I remind you that our website is Drs-say-no.net if you'd like to see our manifesto and sign on. And finally, I want to thank Chelsea Roff so much. It is our great fortune that you were able to give this presentation for us, but perhaps even more important is the great fortune of the world of people with eating disorders, whose world is better for you being in it, not just on this particular topic, but in many other ways. So thank you so much.
Oh,
Take
thank
care,
you. That means a
everybody.
lot.
And look for us and at Chelsea's site, Eat, Breathe, Thrive on the net as well. Take care.
Thank
Bye-bye.
you.